Hi, my name is Dr. Jessica Orchard and I'm a Heart Foundation Postdoctoral Fellow and Adjunct Senior Lecturer at Centenary Institute and the University of Sydney. I've finished my PhD in November 2020 and I also have a background in public health, economics and law, with all my degrees from the University of Sydney. I became a Fellow of the European Society of Cardiology in 2019 and my research aims to improve the quality of cardiac screening programs to prevent sudden cardiac death and catastrophic disability from stroke. Many of my projects have used novel e-health tools and have made best practice recommendations to address various legal, ethical and logistical responsibilities which arise at all stages of the screening process.
Hi, I'm assisting Jessica. I'm her husband, John. I'm a professor or adjunct professor at the University of Sydney. I'm a sport and exercise physician and I'm the Chief Medical Officer for Cricket Australia. I've also had a background in research as well with a PhD from the University of New South Wales and an appointment at the Sydney Uni School of Public Health. And we'll split the presentation up into two sections. I'll introduce the clinical presentation and then I'll hand back to Jess, who will talk about the use of the smartphone ECG recorder as part of the case, because that was a pivotal piece of information that really helped swing the diagnosis in this particular case. So yeah, this case starts as an elite male cricketer who was only age 16 at the start of this case history, although it did proceed on for a year or two after this initial presentation that he made. He was presenting to his team doctor complaining of palpitations that occurred during training. He noticed them more in the breaks between exertional sessions, and he'd say the palpitations would last anywhere from 10 seconds to 2 minutes, but he was getting them about once every 2 weeks over a period of 9 or 12 months. He was recording on his Fitbit that when he did get the palpitations, his heart rate was going up to 190 beats per minute. So he did think it was a tachycardia, but with the Fitbit, he didn't have the exact information of what exactly was going on, and it was self-resolving, so that by the time he presented to a team doctor after training, he said his heart felt normal again. His history in physical examination at rest when he was examined by the doctor was unremarkable. So he did have a sinus bradycardia, which is very normal for an athlete, normal blood pressure, normal heart sounds, and normal chest examination. He did have family history of some arrhythmias, although no one at a young age. So he had grandfather in his 80s and a great uncle, and no other medications or allergies, no drug intake of significance. In particular, he wasn't someone who had a lot of caffeine to explain tachycardia during exercise. He then underwent the standard battery of tests, and resting 12-lead ECG was normal, as was a Holter done for 24 hours and a 3-day Holter. As you're probably aware, it is difficult to do full training with a Holter for an elite athlete. So he was complaining of palpitations associated with high-level training, and it is pretty hard with a Holter monitor to do your normal training. This player is a fast bowler, so even harder still. And he also had a resting echo, which was normal. So his standard workup wasn't able to give us a diagnosis at this stage. He also underwent a screening ECG from the previous season when he was 15 years old. And cricket is like most sports at the elite level, where both the junior and senior players undergo periodic ECGs. Know that in England with the ECB, they do an ECG and echo once in their career. In Australia, we do an ECG every 2 years under the age of 21, and then an ECG every 5 years, along with history and examination. So cricket has a cardiac periodic examination that includes an ECG, as do most elite sports. And in this particular case, the athlete had sinus arrhythmia, which is of course normal, had borderline left ventricular hypertrophy by the voltage criteria. That is now considered completely normal for an elite athlete and quite common. He also had a very small conduction issue in lead V1 there that you can see, slight delay, but it's still within the normal limit. So this is definitely passed both at the time and in retrospect as a completely normal ECG, and in particular the rhythm is normal and not showing any signs of what would cause or could cause a tachycardia. So at this stage we've got a differential diagnosis that it's possible that he doesn't have a tachycardia at this stage because no trace has been made available. But if it is an arrhythmia and if it's a tachycardia, the two most common ones are atrial fibrillation, which even though we associate that with older people, it's still relatively common as a differential diagnosis in athletes, and then other supraventricular tachycardias. We're presuming it's not a ventricular tachycardia at this stage because he's not compromised. He didn't have any collapse. He didn't need to get revived. So he's able to notice that he's got palpitations and a tachycardia, but he's still standing around and comfortably able to communicate. So the presumption is that this is a supraventricular tachycardia of some type, but of undefined cause at this stage.
And so I'm sure many people by now are familiar with smartphone ECGs or iECGs, as they've been around for a little while now. But anyway, I'll describe a little bit about them by way of background for anyone who's not familiar. But I guess at the time of this case, they were a bit newer, and only the single lead version was available in Australia at the time. But essentially, you open an app on your phone and then place one hand on each of the two silver sensors, and then basically the app records a lead 1 ECG rhythm strip for 30 seconds. And then this rhythm strip is available for download via the app and then can be emailed if needed to someone else. So there is now a 6-lead version of the app available and the device. And that's really exciting because you can record all 6 limb leads at the same time in 30 seconds. And that's using the right and left hand. And then you need a third sensor on the left leg, either near the knee or down near the ankle. And that's how the reading gets taken. There is also a 12-lead, which is in development, and it'll be exciting to see where that goes. So what happened next was, after these investigations, we recommended the athlete get a smartphone ECG to try and capture a recording of symptoms when they're actually occurring. And many of the cricket team physicians now actually carry smartphone ECGs, which was recommended by our cardiac panel at the time. So he was able to capture this trace during symptoms, and this confirmed the diagnosis of paroxysmal supraventricular tachycardia. And you can see there very fast heart rate of over 200 beats per minute. So the athlete then underwent an electrophysiology study and an ablation for an AV junctional reentrant tachycardia, specifically a slow pathway ablation. So 9 months later, though, the athlete presented again with a recurrence of symptoms due to a presumed incomplete response to the ablation. And instead of trying to recapture the arrhythmia, the athlete went directly to a repeat electrophysiology study. This confirmed the recurrence of the arrhythmia, and a second ablation was undertaken. These steps were taken in an attempt to defer the need for medication, which could impact his exercise capacity and performance. However, 3 years later, at the age of 19, the athlete experienced symptoms on 2 occasions, which he described as feeling different to the original SVT. He described these as occurring at near maximal exertion levels, where he felt slightly unwell, but then it sort of self-resolved on its own after 5 minutes. He purchased another smartphone ECG device. He'd lost his previous device, and he was able to capture a trace which showed a very different wide complex tachycardia. Usually a wide complex tachycardia like this is treated as ventricular tachycardia, or VT, until proven otherwise. However, with this one, given his history and everything else that was available, a consensus opinion of our sports cardiology panel felt this was most likely SVT with aberrancy. So the athlete underwent another electrophysiology study, which revealed a persisting dual AV nodal pathway with a concurrent left-sided posteroseptal concealed bypass tract. He had a third ablation, which was successful. And at the time of each study, no additional arrhythmogenic focuses were noted other than those ablated. And the good news is that since then, the athlete has reported no further symptoms and has had normal results on his most recent athlete cardiac screening tests. And as you can see here, this is a normal athlete ECG, which shows a sinus bradyarrhythmia with some increased QRS voltages and a minor intraventricular conduction delay, which is similar to his earlier ECG at the age of 15. So really, this case demonstrates the utility of a smartphone ECG, as the athlete was able to capture the arrhythmias, which could not be caught on traditional monitors. The ability to capture the arrhythmia and document it significantly aided in his diagnosis, treatment, and return to sport. In general, these smartphone ECGs are portable, affordable, and convenient for both doctors and athletes. While they don't yet provide the precordial leads, in many cases involving an arrhythmia or an exercise-induced arrhythmia, the device does give enough information that it's the quickest way to document an arrhythmia before it's reverted. And as I said, the amount of information is sufficient for a diagnosis to be made or for a cardiac cause to be ruled out in some cases. And so that's useful reassurance often to rule out a cardiac cause. So for anyone who's interested, I've included a couple of references at the bottom of this slide to our publications on this work with smartphone ECGs. I encourage anyone to look those up. Importantly, I'd like to really thank all our collaborators and co-authors on this project. So Professor John Orchard, who's here, Professor Chris Semsarian, Associate Professor Andre Gerche, Associate Professor Harry Raju, Associate Professor Raj Purinik, Associate Professor Jane Fitzpatrick, Dr. Jacob Jewson, Dr. Mark Young, and Dr. Alex Contouris. They've all been an integral part of this work and this case as well. I'd also like to thank the Heart Foundation of Australia and Centenary Institute for funding, and most importantly, like to thank the Arrhythmia Alliance for the Showcasing SVT Award, which has been a great honour. Thanks very much.